Okay, good morning. So for our final speaker today, I have the pleasure of introducing Anneka Hooft, who is an MD and also has a master's in public health. She's an assistant professor in the Division of Pediatric Emergency Medicine at Benioff Children's Hospital, UCSF. Her research interests are in non-malarial fever, undifferentiated fever, antibiotic use, and health-seeking behavior, specifically in resource-limited settings. She'll be speaking to us today about her work in that area. All right. And then feel free to interrupt, put questions in the chat, or raise your hand if you have any questions throughout, and please stay on mute unless you're asking a question. Thanks so much.
Thanks. All right, let me share my screen here. Can you guys see that okay? Okay, perfect. So yeah, thanks, Teresa. So basically today I'm going to talk about a lot of stuff and kind of some interests that I have in these areas. There's obviously much more work in these areas, so we're not going to touch on all of it. And this isn't a super, like, it should hopefully be done within 30 to 40 minutes. So feel free to ask questions and interrupt me if there's things that you're wondering about in the meantime. But I'm mostly going to talk about, like Teresa said, malaria and kind of when it's not malaria and what to do from there and how that's difficult in some of these settings. So we're going to talk about kind of fever in a couple of scenarios, antibiotic use in these settings, which in particular, we're thinking of malaria endemic settings. So we'll refer to them as in different ways, including resource limited, LMICs, malaria endemic, and that all kind of encompasses the same environments. And then we'll review some current guidelines for diagnosing febrile illness, and then some of the challenges in managing acute illness in these settings, and then what to do from here. So this is the first scenario. So you're working in an urgent care in San Francisco, and you're seeing a 4-year-old male, healthy kid, vaccinated, with the chief complaint of fever. He's had 4 days of fever, some runny nose, maybe a little bit of abdominal pain on and off. Not eating as much, but seems to be urinating okay. In your clinic, his vitals are significant for a heart rate of 148 and a temperature of 38.9, but he looks pretty good. You don't see any focal findings on his exam, abdomen soft. And now here's kind of the same scenario, but instead of working in San Francisco, you're now in a clinic in Mbarara, Uganda. So now you're in a malaria endemic region. Maybe you're in a city, but let's say you don't have a ton of resources. So now you have the same child, 4-year-old male with fever, looks pretty good on exam. So just thinking about, like, for those of you who have worked in these settings or maybe familiar with what's going on, thinking about what their differences are in your differential diagnosis. Mainly, what are you adding for this child in Uganda that maybe isn't on your differential for a kid in San Francisco? And if people are willing, you can put some things in the chat. Anybody? Everyone's sleeping. Yeah, perfect. So Cheryl said, so malaria, parasitic infections, which, malaria is also considered a parasite. So that whole class of infections that, we don't really think of as much unless we're seeing like a return traveler, someone, TB, Marion. So yeah, exactly. Like we don't really see a lot of TB unless it's like a higher risk group. And then, other things like typhoid, et cetera, that are much less common in the United States. There's a ton of other parasitic infections. Yeah, and so, so now we're going to talk about, yeah, exactly. So Kelly said, there's also tons of arboviruses, other mosquito-borne things that are viral that are passed around that we don't really see. Some of these are in the United States, like West Nile, et cetera, but we don't really see much in Northern California. And so we're going to focus now on, how does that change your management? So to start, we'll talk about, malaria testing and who gets tested, what the recommendations are. And some of you might be very familiar with this already, but just a quick review. So this has been changing recently. In 2010, the WHO updated their recommendations to say that every child presenting with fever in malaria endemic regions should be tested prior to treatment, and have this new initiative in 2012, Test, Treat, Track. But there's still a lot of variation in how providers are doing this, based on resources, et cetera, and whether people are just getting treated like they used to. So it used to be where a child presented with fever in a malaria endemic area, they would just treat them. And so you can see from this, malaria testing is getting more consistent and improving. Providers are still having difficulty distinguishing between bacterial viral illness, not having available testing, and then when to give antibiotics. And then there's still not great adherence to the IMCA, and we'll talk about what the IMCI is in a little bit, which is basically the guidelines for febrile illness. And then some children with negative malaria testing are still being treated. So this graph is from a meta-analysis with survey data showing that there's still a good chunk of patients presenting in different settings who are not tested. And this was from like 2010 to 2012, so kind of right after that recommendation went into effect. So most things from there have shown that this has improved since then, but it's still not perfect. And then overall antibiotic use in low middle income countries, especially countries with high rates of febrile illness, is still really high. So in some studies, it's actually as high as 95%, and this is primarily in kids presenting with respiratory illness, but it's also very high in diarrheal disease and undifferentiated fever. And then these are all primarily pluralistic health systems, which means there's several places people can go to get healthcare medication. So that includes purchasing drugs at drug shops or pharmacies without a prescription, going to traditional healers, people on the street kind of selling these illegally, but they're not really regulated enough to enforce that. And then also getting drugs from private and public hospitals. And then we are starting to see antibiotic resistance in these environments. So cultures are not readily available, but in the studies that have performed them, we're starting to see a lot of MDROs, ESBL, primarily these more resistant gram-negative organisms, but then also some MRSA popping up. And then this graph on the left is showing a study in, I think, 8 different countries, which were all in Africa except for Haiti, and Nepal, sorry, 2 were in Africa, and showing the percentage of patients that get antibiotics, and based on their type of illness, you can see it's super high in respiratory infections pretty much everywhere, and then not quite as high, but still pretty high in diarrhea, and then even patients with malaria are still getting, a good percentage of them are still getting antibiotics. So, the WHO has recognized this as a problem and has put out different things to address antimicrobial stewardship. So they have a global action plan on antimicrobial resistance. They put out this toolkit for LMIC specifically to kind of improve antimicrobial stewardship. And then they have this classification system for antibiotics that groups them into 3 groups. So there's the access group, which is sort of the more common outpatient antibiotics like amoxicillin, and then there's a watch group, that's things that we should, kind of keep an eye on how much we're using, and then reserve, which is the really broad spectrum IV antibiotics, antifungals, that kind of stuff. And then this is from the toolkit, and basically, we're not going to go through all of this, but I just wanted to highlight, one of the things that you need is dedicated financial support, and you can obviously see where that might be an issue in a lot of these countries who don't have a lot of governmental resources to do this. So I think the idea is that the heart is there, but there's a lot still that needs to be done to make this happen. And then this is from that same toolkit, and basically, there's a huge kind of pipeline from where antibiotics start to getting to the patient. And we're not going to touch on all of this. We're going to focus mostly on prescribing and kind of where providers get these medications to children. And so this is from a study that I did in Kenya when I was a resident, and there were 4 different sites in Kenya, which you can see in the little boxes. All of these places are malaria endemic. The 2 on the left are near the lake, and then the other 2 are near the coast, so very tropical climates. And we looked at who was getting antibiotics in children with undifferentiated fever. All of these patients were getting malaria tested, so they all had malaria test results prior to getting any medications prescribed. And we found that most of the patients getting antibiotics tended to be younger, usually they're correlated with having URI signs on exam, and then having a flush toilet, which I think is probably a proxy for higher socioeconomic status, which is interesting. And there may be some, kind of similar to maybe what we've seen in the US in the past, that maybe there's some demand from these patients to get a prescription or to get antibiotics. And then the highest correlation was with having a negative malaria test. So that was the biggest predictor of getting a prescription for antibiotics. And then Cheryl's asking, do you see language barriers as a challenge in communicating to patients why antibiotics, any meds aren't prescribed for suspected viral illnesses? So I think here we do. In these settings, not so much, because these providers are usually speaking the language that the patients are speaking. At least in our study in Kenya, that was the case. Like most of the patients were primarily Swahili speaking. Some speak English. The providers speak both, and it's pretty universal there. Like there's not a ton of different dialects or languages, because that is the case in some settings. So that's not as big of an issue. Like usually the providers are able to communicate pretty well with the patients, and they're not seeing like in this population, it wasn't like a lot of, an influx of refugees or something like that weren't speaking the local language.
Got it, thank you.
And so basically what we found was that, pretty much everyone was getting antibiotics. I think the overall rate was like 68% of all comers. And so we go back to, well, aren't there guidelines for who should and shouldn't get antibiotics? And, the main reference for this is IMCI, which is the WHO's guidebook for pediatrics. And so this is from the IMCI, and basically, it starts with looking for dangerous signs. Like, are they able to eat? Are they having seizures? Do they look terrible? Are they lethargic? And then it kind of goes off from there, where it's like, this kid is sick. You need to like refer them to get care. If you're in a referral hospital, then obviously you're going to, admit them and treat them and that kind of stuff, and not worry so much about differentiating them. Like, you're probably just going to give them everything because they're septic, they might have severe malaria, et cetera. And they're kind of, the WHO stance is like, it's worth kind of giving this kid everything and treating them with everything because they look really bad. And then from there, do they have a fever? So this is sort of like you've made it past the danger signs. Here's some things to look for. How long has the fever been going on? Do they obviously have measles? Does it look like they have meningitis? Do they have, URI symptoms, rash, etc.? And then it kind of stratifies them. So again, going back to kind of make sure that nothing's missed, they ask, do they have danger signs? Do they have a stiff neck? Do they look like they're really sick? These kids need to go urgently. In the middle, kind of, is it malaria or not? If it looks like more of, pneumonia type symptoms, give them Cotrim. Does it look like it's probably malaria? And obviously you should have a test with this as well. And then follow up. And then the last one, which is sort of like the catch-all and kind of what we're going to focus on, is, do they have a runny nose? Do they have obvious measles? Okay, no other cause of fever. And that's just like everything else. And then it's like, give them Tylenol, have them follow up. So that's great, but in reality, this is what happens. So here's our guidelines, is there another cause of fever? And it kind of stops. And so when we talk to providers, this is a quote from one of them, and basically saying, we're using antibiotics so much. And according to the guidelines, when there's a fever, there's no other positive cause of fever that you can think of. The IMCI doesn't really cover throat infection, and that guideline basically doesn't tell you what to do or what else to look for. It's just kind of like, here you go. And then as far as the treatment goes, give them paracetamol, advise them to come back in 2 days. And so the providers are saying, that they take so long at home, these patients don't come in, and when they come in, they're arriving too late and we can't do anything. So they're worried, by the time patients present, they're already too sick to get help. And then they basically say, we're giving the antibiotic for prophylactic purposes because you don't want a child to get worse and you're really not convinced that they're going to come back for follow-up. So you can see that there's a lot of dilemmas here with these patients. So there's a lot of overlap in symptoms, between or among many illnesses, so malaria, URI, pneumonia, et cetera, you know, these viral, arboviral diseases, they don't have the diagnostics to differentiate them. So usually what's available is a malaria RDT, an HIV rapid test, and a hemoglobin, maybe. Sometimes urine, sometimes not. They don't have really a full list of medications or supplies. They might not even have paracetamol to give them. And, you know, if you can imagine that a lot of these patients want some sort of treatment. So when you have like nothing to offer except for amoxicillin, you know, maybe that's one of the reasons. And then some of these providers don't even have training for pediatrics. So most of them are not physicians, especially in these clinics and more rural settings. They're clinical officers, which are kind of like PAs, and some of them haven't had IMCI training. They may have not seen a lot of pediatric patients and then get put in these settings where they have high volumes of pediatrics. Clinic volume is a big issue. So there's not enough health workers. They're seeing a ton of patients. You know, they don't have the time to spend to like give a kid an antipyretic and see if they look better or whatever. Like they can't do a lot of times a long evaluation or counseling. And then we don't really know the true prevalence of serious bacterial illness in these settings. So it's hard to not give antibiotics when you're not sure how likely it is that someone's going to have, you know, a severe bacterial infection or not. So back to our scenario. So now we have a malaria rapid test and it's negative. He doesn't have HIV. The family lives 4 hours from the referral center and they don't really have reliable transportation. So, you know, based on IMCI, do we say this is a viral illness? Do we just watch and wait? Kind of thinking about what you would do if you were the provider in this setting. And so people have thought about, you know, well, what if we make IMCI better so that this isn't as big of an issue? So can we revise the guidelines? Can we add in some biomarkers, additional laboratory testing, maybe ensure we have consistency of other tools available, such as pulse oximeters, because a lot of times these patients aren't even getting pulse oximetry or consistent vitals due to lack of supplies. And then, you know, can we figure out something with post-discharge follow-up that maybe we can ensure that a little bit better and have some confidence that these patients are going to return to care. And so this is from a study from Dr. Kim Balso, who works at UCSF. And basically all they did was just add in a pulse ox to IMCI at these mobile clinics in Malawi and found out that it helped a ton, like more than they even expected, because the results were so dramatic that it decreased the odds of antibiotic prescription by 7-fold. And you can see in this graph that they had a control site where they basically didn't change anything. And then the orange one is just they did IMCI training and kind of ensured that people were using the IMCI, and those were pretty equivalent with super high rates of antibiotic prescription. And then the yellow bars show how much it was reduced when they just added pulse ox to IMCI. And then they also saw that this increased people's frequency of diagnosing a common cold in comparison to diagnosing like a lower respiratory tract infection or kind of undifferentiated respiratory illness. So it seemed to improve people's confidence in saying, hey, this is just a URI. We don't need antibiotics. And so there's been a lot of other guidelines and different prediction models that people have looked into. And this is kind of a little representation of all of them from a study that kind of looked at, it basically validated all of these in another population in Tanzania. So looked at how well they performed in the same group of kids in predicting serious bacterial illness. And what you can see is, so the red circle is how many kids got antibiotics that didn't have serious bacterial illness. And then the overlap in purple is the ones that got antibiotics and did have serious bacterial illness. And then the blue is the ones that had serious bacterial illness but didn't get antibiotics. And you can see where you have to kind of balance sensitivity. Like you don't want to miss the kids that do have it. So you're probably going to have to overtreat some, but then you also don't want to overtreat everybody. Like you want to be a little bit judicious with your antibiotic use. And the bottom line is that none of these are great. So they all miss a decent percentage of SBI, and they all give antibiotics to way too many kids. And from that study, they looked at, what did the kids have that had serious bacterial illness that were missed, because the population they validated on all had pretty rigorous bacterial testing. And you can see like they're not missing trivial things, like they're missing a lot of typhoid. There's a good chunk of kids that have true bacteremia. We have a lot of UTIs, because a lot of these don't have any sort of urinalysis included in them. So it's not like we're missing, a few cases of pneumonia, like they are missing pretty serious infections. And so this study was done by a group in Switzerland, and they basically created a better IMCI where they added in urinalysis and rapid typhoid, and also included some differentiation of symptoms and things from kind of in that branch point where it's like, hey, there's a fever, what else could it be? And they actually added in some different symptoms and kind of like other things to look for. This is sort of like the whole details of it, but you don't have to know all of that. And then, added in if they're under 2, like they should get a UA. If they have any abdominal symptoms and have fever and they're older than 2, which is kind of the age risk for typhoid, then you should do a typhoid test. And they found that just doing that reduced antibiotic use dramatically increased or improved clinical outcomes, and also decreased the diagnosis of pneumonias and UTIs. And then from there, they actually went on to do a little bit more and add in some biomarkers. And so this is just looking at they have like a little tablet thing that they use. And so they added in making it all electronic, which was what the Almanac started with, of revising the guidelines and making it more user-friendly on a tablet, but then also adding in CRP and procalcitonin, I think either one or the other. And you can see that, it walks you through, you put in the results. There's more screens than this, but this is just like the basic gist of it. And then it actually tells you, like based on what you input, this is probably bacterial pneumonia, here's the dose of what you need. And then this kid also has a fungal infection, here's the dose of what you need. And so their results were also pretty striking, that, just adding CRP and Procal to this Almanac algorithm of walking through the guidelines reduced antibiotic prescription even more. And then they also found that clinical failure was reduced, and only 4% of these kids ended up getting antibiotics later, which was the same as the percentage in the group that didn't use the EPOC algorithm. And then you can see the prescription rates based on the illness, and obviously pneumonia again is the big one where it cut down drastically, but some decreases in the other ones as well, including GI infections, fever without a source a little bit too. And then you can see like the kids who looked really sick, it actually increased the antibiotic prescription rate. So, like compared to that graph we saw with the circles, like that's probably a good thing that they're recognizing that a bit more. And then one other kind of, we talked about follow-up care. So this is not, it's somewhat related, but a project that I'm working on with a group who does a ton of studies on this in Uganda at multiple sites, and it's called Smart Discharges. And basically this program is for kids who are admitted. So rates of post-discharge mortality are super high in these settings, like 5 to 10%, which, if you think about like if 5 to 10% of the kids that you sent home from the hospital here was that high, like people would never come to UCSF, but this is kind of like the standard in these settings. And so this group looked at, how do we reduce this? And this is sort of like all the things they do, but they basically admit the kids, screen them, and then they have a prediction model. And then the intervention is very simple, basically just a lot of education and counseling, and then planning follow-up care based on their risk level. And they're showing that it's already helping a lot. So they look at admitted patients with suspected or proven infection. The intervention is just risk stratified education and follow-up. So basically the higher risk patients get more follow-up set up for them when they are discharged. And this is not follow-up at the same clinic. It can be like in their local health centers, et cetera. And they're still enrolling at this point, but the preliminary results show that it's probably reducing mortality by about 30% and increasing the rates of health seeking by at least threefold. So back to our patient. So now this kid has, normal hemoglobin, normal oxygen saturation. Let's say we have all this stuff available. He has a CRP of 44, Procala 0.98, which are below the cutoffs for the epoch. So like 80 is the CRP cutoff, and I think the Procala is 4 maybe. So he's below the cutoff of high risk. He doesn't have any other localizing symptoms or findings. So now, how do we feel? Are people more comfortable sending him home? Would you be more comfortable if you were a provider in one of these settings of sending him home versus giving him antibiotics and then sending him home? So altogether, looking at kind of how we can improve this, there's, I think, a few components. So we looked at prediction models, seeing, what should be included in the guidelines, what makes someone higher risk for progression to more severe disease or having a true bacterial illness, then creating guidelines from this, but also training is a huge part of that. So there's no point in initiating a new guideline if no one knows how to use it. So guidelines, making them user friendly, like the tablets that they use in the almanac and the epoch, and then making sure that everyone knows how to do that and is comfortable seeing pediatric patients, and then adding in some POC testing. We still don't, I think it can be argued like no one really knows what the perfect test is for this. We kind of have to use what's available. So that's why people are focusing on CRP and procalcitonin, but there are others who are looking at biomarkers that are further up the pipeline. So maybe haven't been made available routinely in laboratory settings, even in higher resource settings, and figuring out what to do from there. But obviously that's going to be further down the line and it's going to be expensive. And so right now, focusing on what's available and what's most cost effective. And then, is there a component for follow-up care in this? So is there some intervention where ensuring patients have better follow-up that would improve people's confidence in sending them home and also making sure that we're not missing severe illness? And then, putting this all together to have a whole algorithm that's risk stratified for management and follow-up. So it tells you, who's at higher risk that needs antibiotics, who's at higher risk that needs closer follow-up, et cetera. And so how do we make this happen? These are just some suggestions. I don't have all the answers, but like we said, training and guidelines for febrile illness, ensuring follow-up. This can be with community health workers. It could even be by phone, educating caregivers so that they know when they need to come back, regardless of whether it's scheduled or not, and where they should go for that. Like not going to like the pharmacy if they think the child is getting worse, but going to their local health center or the referral center if they're really sick or something like that. And then also improving access to hospitals and health centers. So making sure that these kids have a place that they can go. And then improving access to diagnostic testing and equipment. So in reality, these things look good in the studies, but these aren't things that are normally available in these settings. So how do we figure that out if these are working? How do we get those tests and equipment to these settings? And there are groups that are working on this. Like there's a group within WHO that specifically looks at how to get equipment and testing kind of down the pipeline from development to making it less cost prohibitive and getting it out to where it's needed. And then, more studies on risk prediction, how well these algorithms perform, evolving bacterial pathogens like resistant bacteria and where they are popping up, because every setting is different. So what we might do in Kenya might be different in Tanzania, tailoring these guidelines by the epidemiology of the location and the available resources. And I don't know if you guys went to Josh Bress's talk, but they Novi Guide focuses on within their model in the guidelines. They have actually the specific treatments and antibiotics available at that site, and it changes depending on their stock. And so the guidelines will actually account for, if you're out of amoxicillin, like what else can you use, et cetera. And then community education. So, teaching, and this is a problem in the US as well, but teaching people about antimicrobial stewardship and resistance, and what problems might arise with too much self-treatment, with over-treatment, and treating everything that's a fever with antibiotics, even if it is just amoxicillin or one of the lower classes of antibiotics. So that's all I have. These are some of the references. And then questions, anything people want to discuss. And then just a thank you to all the people that I've worked with in these settings. The clinical teams and research teams in these different sites work really, really hard. And so none of these things are possible without them being on the ground all the time. So.
I had a question. So I think after this talk, I am grateful that we have like easier follow-up here. It seems like, when we see patients in the ED, we could just like say, hey, if this doesn't go well overnight, go see someone tomorrow. And it seems like it's easier than what it would be if someone had to drive like 4 hours away. What are some of the alternatives that families can go to other than coming back to the clinic or the health center that they originally went to?
Yeah, so it depends on where you're working, but a lot of these places have community health workers, and they have variable levels of training. Usually they have some kind of basic training, but they're not like full medical providers, but their job is to kind of monitor things in the community. And sometimes they have like specific things that they're like public health measures that they're kind of there or kind of deployed to look into. Like maybe they're working on getting people connected to care for HIV or something like that. But there's someone who's out there and around. So there's some thought in like having them as a resource and kind of having them as someone that people might be able to approach so that they could help them find care. And then a lot of these places have smaller health centers that are closer to the like smaller villages. So usually the referral hospitals, which are like the big hospitals in the big cities, similar to here, where it's like the urban academic hospital where they can admit children. A lot of the smaller ones can't do that, but they will see children, and they do like the normal stuff like vaccinations and kind of routine healthcare, but they just can't do more testing or keep kids overnight, that kind of stuff. So they can go there. Some of those, depending on where you are more or less accessible. So, certain countries like Mozambique doesn't have great ones anywhere. They just have like a very poor health structure because they don't have a lot of money. Some of the other countries like mid-level in sub-Saharan Africa, like Tanzania, Kenya, do have decent access, but kind of variable degrees of quality. And one of the studies that we did talking to people about where they go for care, which I didn't talk about here, but people sometimes don't trust those places. And so it's really hard. You have to balance a lot of things, because some people are like, when my kid is sick, like I'm not going to waste my time at these little health centers. They don't know what they're doing. I'm just going to go to the referral center, but they can't get to the referral center easily. So they don't go every time their kid is sick. Like it's not worth it. So yeah, like that's another thing that you have to balance. And then the other thing that we looked at in this other study that I was talking about is, people oftentimes go to traditional healers, which are like herbal medicine providers. And there are like one of my mentors for that project has a whole study looking at using traditional healers and kind of incorporating them into the formal health system, especially for HIV care in adults. And so there's some thought that you could also do that in pediatrics or with other things, where you could give them some basic training and like, recognizing danger signs, that kind of stuff. And they could actually be incorporated into the health system and used as sort of like sentinel providers, rather than kind of ostracizing them from the formal system, because we know people are using them. So, why not have more manpower in picking up this kind of stuff? So lots of different things.
And then do you kind of like assess their availability or access to transportation too? Because like when I worked in Ghana in this like rural community, we had like a little clinic set up, but the nearest health center would be like 45 minutes away. But it doesn't sound like too much compared to like 4 hours. But if there's no transportation, 45 minutes is still like hard to get to if there's a sick child.
Yeah, so pretty much every study that I've ever worked on asks, like they'll ask like how long does it take you to get to the nearest health center? I think the one in Kenya, we did also ask them like how they got to the health center. So yeah, people do take that into account. Some of the more robust studies will also even like map people's locations using like GIS mapping and that kind of stuff to determine how close they are to both like a local health center and a referral center, and account for that in their analysis. I don't think, like, none of the ones that I worked on recently, I think Smart Discharges is eventually doing that, but hasn't started doing it yet. But they are going to try to look at like exact distance to a health center.
Thank you.
Mm-hmm. Anyone else?
If you could only pick 3 tools or point of care tests, what would be the 3 things that you would pick to implement?
Oh man,
I know.
I think a pulse ox has to be on there. And you know, ideally that would be kind of like the whole machine, so it would give you the heart rate and stuff too. I think most of them do that, so you get like a full set of vitals. Like ensuring that happens on every child, I think, is huge. I think, you know, I don't know that you necessarily need 2 different biomarkers, but I think either a CRP or a procalcitonin, and having a little bit better sense of how good the cutoffs are, because I think we don't really have that yet. And then, I mean, I don't know if we're talking about new things. I think malaria is hopefully gonna be there already, but definitely need that. Yeah, and then I don't know about a third one. I would have to think about that, because I think, you know, the other thing is like these are all very you know, similar to the US. Like they do have seasonality, so like you could see where in flu season it might be super helpful to have like a rapid flu test versus like in the US, like when you're starting to see flu, maybe, you know, that kind of thing. And so I think, like, you know, the third test might have to be more region and time specific depending on what you're looking at. I think we're never going to have, you know, like even here, we're never going to have like a huge viral test that we can easily do on everybody until that becomes much cheaper and faster to do. So I don't see a lot of utility in doing that, but yeah, it's definitely tricky. I don't envy people working in these settings. It's much more cognitively challenging than when we see kids with fever here that look great and we're like, oh, you're fine, you can go home. And the other thing someone asked me too when I was talking about this is, you know, like, are these kids vaccinated, you know, similarly to the US and that sort of risk? And, you know, in most settings they are, like, they get the general, you know, basics. They might not get like chicken pox, but they get, you know, the usual like pneumococcus, Hib, that kind of stuff. So, you know, the bacteremia risk from those theoretically shouldn't be great, but, you know, that also changes with how much access they have to the health centers and that kind of thing. So
yeah, it's interesting. Where I work in Tanzania, they have better vaccination rates than Marin. So
yeah, and that's what I've seen too. Like a lot of these places, people know that the health risks are high, and, you know, they are like super grateful to get vaccines and are like super on top of it and line up at the health center because they're like, yeah, like, you know, this is something we can get and it's free and we're going to do it, versus here where, yeah, people have more misgivings and are, you know, reading on Google that they're going to have autism or whatever and think that they know a lot about it. So
yeah, I think one of the challenges, yeah, there's more trust. I think one of the challenges of an algorithm, which I think is definitely a step forward and needed, is I think of how we practice clinical medicine, and you kind of integrate like all of the information, and then there's this like caveat, which is you know, based on your clinical decision making, right? So even if your CRP is low and the procalcitonin is low, but you have a patient who looks very poor in front of you, you're still probably going to broadly cover them and do a rule out until, or, you know, or admit them or have them come back for follow-up. There's all these kind of like things that you can build in. So it's not as like black and white as, well, their CRP and procalcitonin are low, so we're going to discharge them, and then they're like, you know, lost the follow-up. There's always this like this cushion in there for like the clinical decision making that has to be built in, I think, to any algorithm, because it's never black or white. There's always shades of gray in there. But that being said, like to your point of like respiratory viruses, like if we had a rapid respiratory viral panel that we could do in outpatient setting that didn't require like a lab infrastructure, like think how reassuring that would be. Like I certainly get back that a patient has rhino or RSV and I stop the antibiotics and I feel a lot more confident watching them, you know, in the hospital or even, you know, in outpatient setting, knowing that we have a known viral pathogen. So that would be a huge one.
Yeah, and I think like what you were talking about, the other thing we didn't touch on that there are people studying is also like the referral system itself. And I think you're doing some work with that too, or you, I don't remember, like, or Kim was, I think Kim was looking into that. But yeah, looking at like, you know, the referral system itself and like how these providers could maybe get advice on the kid, like say that they aren't sure about, because really like the level of training that these providers have is very algorithm and flowchart based, that they're not trained to do clinical reasoning as much, and you know, don't have like a full medical school and, you know, residency and all of that. Like they're very much trained to kind of see a patient, check like, do they have this and this, do they have that and that, and like go from there. And some of them get very skilled at doing that and in kind of learning clinical reasoning once they get more experience, but a lot of them like are just thrown into these places like right after they finish their training, and so they don't have that level of development that you get from those things. And so, you know, how do we have like resources for them so that when they do think, when they're not sure or someone's falling off the algorithm, that they can like easily get in contact with a specialist, like a pediatrician at the referral center, and maybe get some help rather than just like referring them automatically or not referring them. And then also, you know, the referral, even if they do decide to refer them, usually there's not a lot of infrastructure in place to communicate what's going on. And so they end up just like sending them somewhere. Sometimes they're like holding a piece of paper. Sometimes they don't even have anything. And so just kind of streamlining that a little bit more so that there's more support in general.
Yeah, there's lots to do.
Yeah.
Lots of work for anyone who wants to join.
Yeah. Great. Well, looks like we're done a little bit early, so I'll let people have their extra 15 minutes, but thanks for coming.
And I'll put in the chat our eval, if you can also fill that out.
It's kind of just in the beginning stages.
There is. So we did a study on caregivers and basically interviewing them about where they go for care. But my mentor on that project has a lot of published work in the adult HIV realm, and she also did another study on admitted patients with like pediatric patients with similar like febrile illness, malaria, et cetera, and asked them about their care seeking behaviors prior to their admission. So I can send you her name and like the studies that I have that are specific to pediatrics, and then you can look. Like I know she's published a few things recently on the HIV stuff. Like she has a like long running study looking at different like she started with looking at like that she interviewed healers, she looked at where people go and surveys and all of this, and then she did an intervention where she started doing HIV testing with the healers, and so all different stages along there's at least something published. So, and that was in Uganda. So yeah, so I can send you more on that.
Thank you.
Mm-hmm.
Okay, well, thank you so much. I really appreciate it. And we'll talk again soon, as you know. All right, thank you, everyone. We'll see you tomorrow.
Thank you.
Bye-bye.